Welcome to Course 1.0, Mastering Implants, from Dental Vision 3D. This lesson is designed especially for dental students, beginning implantologists, and anyone preparing for dental implants. Today, we will build the essential foundation for the entire implantology course, understanding the anatomy, physiology, and hidden dangers of the bone. While most patients believe implants depend on the brand, the price, or the dentist's hands, professionals know the truth. 70 to 90% of implant success depends on the bone. The implant is only a device. The bone is the living biological environment that determines whether the implant integrates or fails. Today's lesson will help you think like a surgeon, deeply, structurally, and three-dimensionally. Let's start with the basics. What you are seeing here is the jawbone, which is divided into two main structures, the maxilla, upper jaw, and the mandible, lower jaw. The part that holds the teeth is called the alveolar ridge, and this is the exact site where dental implants are installed. Once a tooth is removed, the bone begins to slowly, or sometimes rapidly, disappear. This process is known as bone resorption, and it is one of the biggest challenges in implantology. Why does bone disappear? Because bone is a living tissue that responds to load. When the tooth is gone, the bone loses its mechanical stimulation and begins to shrink. In the first year after extraction, a patient may lose up to 40% of bone volume. Vertical loss, horizontal loss, and changes in density happen simultaneously. This is why immediate or early implantation is often recommended. If the surgeon waits too long, the bone may require grafting, sinus lifting, or complex augmentation procedures. Next, let's look at bone density. We classify it into four types: D1, D2, D3, and D4. D1 is extremely dense cortical bone and is found most commonly in the anterior mandible. D2 is a mix of dense cortical and porous trabecular bone, typically seen in the posterior mandible. D3 is softer bone, more common in the anterior maxilla. D4 is the softest, almost spongy bone, usually found in the posterior maxilla. For a surgeon, these distinctions are critical. Dense bone provides excellent primary stability but risks overheating during drilling. Soft bone requires a different drilling protocol and often cannot support immediate loading. Many implant failures occur because the surgeon misjudged the density and used an inappropriate drilling technique. Now let's turn to the upper jaw, the area with one of the most important anatomical challenges, the maxillary sinus. This is a large air-filled cavity located directly above the roots of the upper posterior teeth. When molars or premolars are extracted, the sinus expands downward in a process called pneumatization. As a result, the bone between the oral cavity and the sinus floor may thin to just a few millimeters. Placing an implant without sufficient bone height increases the risk of sinus perforation. This may lead to sinusitis, chronic inflammation, and failure of the implant. To safely place implants in this region, surgeons often perform a sinus lift, either an internal, crestal, or external, lateral window approach. This procedure lifts the sinus membrane and adds bone grafting material to create a stable foundation. We will explore this operation in detail in a later lesson. The key message for the upper jaw is simple. Bone height is your greatest limitation. Never plan implants here without 3D visualization and precise measurement.
Now let's move to the lower jaw, where the most critical structure is the inferior alveolar nerve. This nerve supplies sensation to the lower lip, chin, and teeth. It runs through the mandibular canal, beginning at the mandibular foramen and ending at the mental foramen. Placing an implant too deep in the posterior mandible can damage this nerve. The consequences may include temporary or permanent numbness, altered sensation, or pain. This is one of the most severe and feared complications in implant surgery. Surgeons must always measure the distance from the alveolar crest to the nerve canal with extreme precision. A minimum safety margin of 2 millimeters is the standard. In some cases, bone grafting or shorter implants may be needed to maintain this safety zone. Another important structure in the mandible is the lingual undercut, a concavity on the inner side of the jaw. If the surgeon does not detect it on a 3D scan, drilling may perforate the bone and cause a life-threatening hemorrhage. This is why panoramic X-rays alone are no longer acceptable for planning implant procedures. To prevent all the complications we've discussed, sinus perforation, nerve injury, insufficient bone height, incorrect drilling protocol, or unrecognized anatomical variations, the surgeon must rely on 3D cone beam computed tomography, or CBCT. CBCT is the gold standard. It provides detailed information about bone density, height, width, the exact position of the sinus, the nerve canal, undercuts, cortical thickness, and angulations. With CBCT, surgeons can create a virtual surgical plan, selecting implant length, diameter, exact angle, entry point, and depth. Computer-guided surgery further enhances accuracy by allowing implants to be placed through a surgical guide. This minimizes human error and provides predictable, safe outcomes. Now let's connect everything in a practical context. Imagine you are planning a single implant in the lower molar region. The bone height is 13 millimeters. The nerve is located 11 millimeters below the crest. The surgeon must select an implant no longer than 9 millimeters to maintain a safe zone. Without CBCT, these calculations would be impossible. Or imagine placing an implant in the posterior maxilla where only 3 millimeters of bone remains. Without a sinus lift, this case is impossible. With proper planning, however, it becomes routine. Before we conclude, it is essential to understand one more concept: osseointegration, the biological process where bone cells grow onto the implant surface. This process depends on bone quality, blood supply, surface technology, insertion torque, and surgical technique. Good bone anatomy supports good osseointegration. Poor bone conditions require advanced planning and often additional procedures. To summarize today's lesson, implant surgery is not about titanium. It is about anatomy, biology, and precision. Bone density, bone height, and anatomical structures such as the sinus and nerve canal define the entire strategy. This was Lesson 1, Basic Bone Anatomy from our Implants Course 1.0. In the next lesson, Lesson 2, Comparing Implant Systems, you will discover why visually similar implants behave differently and which design features lead to long-term success. Be sure to continue the course, subscribe to Dental Vision 3D, and let's move to the next lesson. Your journey into advanced implantology is just beginning.